It's morning here, and the theme I'm going to be talking about today really has got me tremendously excited, and I'm sure it'll get you excited too as I go on with the story. But it all started in 1997 when Viagra came. And when Viagra came, the urologists began to prescribe it as if there was no tomorrow. And when they prescribed Viagra, they discovered that a majority of the diabetic patients that they had did not respond to Viagra in terms of improvement in erectile dysfunction. And since they did not improve, and they were not aware of the fact that when Pfizer conducted the trials for Viagra, only about 45% of the diabetics had responded. About half of them did not. And these guys then got referred to me for treatment. And being a methodical endocrinologist, I started off by measuring testosterone, LH, FSH, and prolactin, and all of them. And what emerged was that a majority of those referrals with erectile dysfunction, with diabetes, were running low testosterone concentrations. I got so worried that I asked the laboratory to check the assay. And in fact, they came back to me 2 weeks later and said, it's only your patients who have the low testosterone, not others. So clearly, we had discovered something new, that type 2 diabetics who have erectile dysfunction probably have hypogonadism at the same time. Now, when we look back at the literature, we did find some references in epidemiology of the association of low testosterone with type 2 diabetes and obesity. But no clinical syndrome had been described. These were epidemiological studies of scientific interest. So we began to collect data. And into the year 2000, I was joined by another Amesonian who graduated in 1996, Sandeep Dinsa. And he's remained my partner in all of this all these years. And we then published in 2004. And can I have the next slide? Or shall I change them myself?
Pratap, change from your side, or Hardik, please change the slide.
So can Hardik, can you listen to me every time I ask you to do that,
No, no,
please? Yeah.
they
So
will,
here we
sir.
are. Here we are. So in 2004, in the Journal of Clinical Endocrinology and Metabolism, we published the first paper with Sandeep Dinsa as the first author. And as you can see on the left, 1 in 3 type 2 diabetics was hypogonadal. And we found it very difficult to believe ourselves, but we had confirmed the data, published it, and soon after that, Brazilians, Italians, Brits, and Australians globally confirmed the syndrome that in type 2 diabetes, hypogonadism does exist. The other part of the interesting story is that if you look into the right side of the slide and look at the histogram, the LH and FSH concentrations in these patients were low. In other words, it was a syndrome of hypogonadotropic hypogonadism. Prolactins were normal, so prolactin was not to blame. Next slide. Now, what was interesting? No, what was interesting was that neither the duration of diabetes nor the severity of diabetes in terms of HbA1c was related to testosterone concentrations. The only correlation that we found, and this is going to be the story of the day as I go on, was with BMI or body weight. The higher the body weight, the lower the total testosterone and lower the total free testosterone. So clearly, weight had an important contribution to make to this abnormality of testosterone. Next slide. And then we looked at type 1 diabetes just to make sure that it was not a universal diabetic phenomenon and that it was specific to type 2. So you can see here now that when we did this comparative study between type 1 and type 2 diabetics, type 1s were happy, normal testosterone. Type 2 were the ones who had the syndrome and had significantly lower testosterone levels. And by this time, having seen enough patients, these guys were actually suffering from sexual dysfunction and and so on. And we'll go on to other aspects of this as we develop this talk. Next slide. And here then, we looked into, in 2010, we published the first large study on obesity. And you can see non-diabetic obesity itself is associated with a prevalence in that age group of middle-aged 50-year-old people, 40% prevalence of hypogonadism. And if you had diabetes on top, on the right, you can see the histogram showing even a higher prevalence. So while obesity seems to be the central defect in this, diabetes adds to it as well. And just sort of to start off the story, as you will see later on, insulin resistance is deeply involved with this situation. Next slide. Now, while we were looking at all of this, the Italian group by Maggie et al. Showed that elements of metabolic syndrome, as they increased from 0 to 4 to 5, were associated with decreasing, progressively decreasing testosterone concentrations. So really, in due course, low testosterone will also become a feature of the metabolic syndrome and obesity. Next slide. The next question that arose in my mind as a clinician was that all my patients on whom I had described all of this were middle-aged, but these guys already had their families and their children. Whereas where it mattered most was in adolescence. So we then carried out a study along with the Children's Hospital colleagues to look into boys, obese boys, between the ages of 14 and 20 years. And what emerged again was startling. You can see that the total testosterone concentrations in the obese boys were nearly 50% lower, while free testosterone concentrations were about 33% lower. And I might as well introduce you to another concept here. Insulin resistance is known to be associated with reduced sex hormone binding globulin, and this is the reason why there is that slight discrepancy of 50% versus 30%, 33%, because in these patients you need to have free testosterone or calculated free testosterone with inclusion of SNBG so that you can look at the free testosterone concentrations, because just doing total could be deceptive. Next slide. And now, following our study in 2013, followed a study from Holland from a very seasoned testosterone group. And you can see that the dotted line of the obese children is so showing you consistently low testosterone in a dynamic fashion across the various stages of puberty. So clearly, in children, the syndrome also exists and is important, because these are the guys, if not treated adequately or managed adequately, will end up with a lifetime of hypogonadism and lifetime of infertility. Next slide. So, what is it that is leading to obesity causing a low testosterone? Next slide. So, we know that testosterone is converted to estradiol by the enzyme aromatase, as you see on the right, and that this enzyme exists in large quantities in the adipose tissue. And therefore, the first hypothesis suggested by people was that perhaps these patients have an increased amount of aromatase in their adipose tissue and therefore are converting large amounts of testosterone to estradiol, and estradiol is then getting back to the hypothalamus to suppress the hypothalamo hypophyseal axis to result in low gonadotropins and then in turn getting low testosterone. However, when we looked at the real data in on estradiol in these patients, the next slide, and you can see that the free testosterone concentration in hypogonadal males with low testosterone was significantly lower, not higher. And therefore, at that point in time, When we published these data, we suggested strongly, and that's been confirmed again and again, that estradiol, if anything, is low in these patients and therefore is not the cause of the hypogonadal state. So, what is it that is the cause of the hypogonadal state? Next slide. And here you have an animal model. Oh, next, go back, go back, go back, go back to the, no, next one. You missed one slide in the middle. Yeah, that's it. So, you can see here in the B sort of panel, the seminiferous tubules of mice who had a knockout of the insulin receptor in the brain. So these are animals that do not have an insulin resistance selectively in the brain. And what Ron Kahn's group at Joslin Clinic were trying to establish through this model was that the knockout of the insulin resistance in the brain, knockout of the insulin receptor in the brain, would lead to an animal with metabolic syndrome. They got that. But what they did not expect, as often happens in science, is that the animals were hypogonadal and their LH levels were low. So they had an animal model of hypogonadotropic hypogonadism where the insulin receptor was missing in the brain. So that then led us all to conclude at that point, since we can't do a similar experiment in the human, even my fellows would not allow me to do a brain biopsy on them. So we decided that it's probably an issue of insulin resistance in the brain that is leading to this syndrome. Next slide. And therefore, just briefly, so we think now that there is a decreased insulin and leptin signaling in the central nervous system, which then leads to less of a protein called kisspeptin, which is entirely in the brain. You can't measure it in the peripheral blood. But this kisspeptin normally stimulates the GnRH in the hypothalamus, which in turn then stimulates LH and FSH and leads to adequate spermatogenesis on the one hand and to testosterone secretion on the other. So this is where we are in terms of the pathogenesis of the syndrome. Next slide. And then the next question was inflammation. Since obesity is associated with inflammation, we looked at the possibility that the hypogonadal patients may have higher CRP concentrations. And you can see that the CRP concentrations, as we published way back in 2006, CRP concentrations are high. And as I will go through again in a while, that inflammation is a major point of interference with insulin signaling, because at the level of IRS1, which is the key level at which insulin signaling occurs, a whole lot of pro-inflammatory cytokines interfere with IRS1 and suppress it. So clearly, it's consistent with the idea of insulin resistance. Next slide. Now, on to a large study that we published in 2016, and these are the beginnings of the data. Since these patients tended to be more obese and had less testosterone, we asked the question whether they had an increased level of insulin resistance. And you can see that the insulin sensitivity in these patients is about 35% lower than that in type 2 diabetics who are eugonadal, who have normal testosterone. So clearly, low testosterone was associated with greater insulin resistance. Keep that in mind, because you'll see a reversal of this as we talk about testosterone administration. Next slide. And here we are. To explain the insulin resistance, we've got actually molecular data. So from the fat biopsies obtained from these patients, we were able to show that the expression of the beta subunit of the insulin receptor, RS1, AKT2, and GLUT4, the glucose transporter, all those four elements were significantly lower in the hypogonadal patient. So clearly, we now know why the hypogonadal patient is insulin resistant at the molecular level. Next slide. And here you see another element, AMP kinase. I think all of you know that exercise and metformin work through enhancing AMP kinase. So we asked the question whether testosterone could have a relationship with AMP kinase. And as you can see on the left side, both in the adipose tissue and in the muscle, AMP kinase expression is significantly lower. And activated kinase, which is phosphorylated AMP kinase, is also lower, as you can see on the right. Next slide. And then, of course, we've talked about this, the summary points, but the other thing I wanted to say in relation to the last slide, that the AMP kinase increases after 6 months of of testosterone therapy. Next slide. So go on, next slide. So what are the general effects of testosterone therapy? Now, as I'll show you in a while, increase in insulin sensitivity and glycemic control, as I'll show you towards the end, obesity reduction and improvement in sarcopenia, buildup of muscle, and reduction of inflammation. And as you will see, over a protracted period of time of 11 years in our study, just published last week in Diabetes, Obesity, Metabolism, the profound effects on lipids and on hemoglobin, and of course, sexual symptoms, of course, fatigue and anemia, and so on. Next slide. And here is the experiment that we did. This is supported by an NIH grant, for a large NIH grant, to look into the details of the molecular events following testosterone. As you can see, the hypogonadal patients maintained their testosterone concentration over a period of 26 weeks. And of course, testosterone administration, which was done intramuscularly in this series of patients, also maintains normal testosterone concentrations during this period. Next slide. And here you can see something very interesting. So that in the testosterone group, you can see, if you look at the subcutaneous and the visceral fat mass, in the testosterone group, it goes down significantly. Hepatic fat also goes down significantly, but lean body mass increases. So in your patients, when you give them testosterone, you will notice that the belt size will go down because the abdominal fat diminishes, but their skeletal muscle increases significantly, and it's almost equal distribution. Keep this phenomenon in mind, this study done over a six-month period. Next slide. And here you have actual measurements of the insulin sensitivity done with a clamp technique, which is the standard technique. And you can see in the testosterone group on the left, the increase in about 35%, which is almost mathematically identical to the increase in resistance that you saw in the first slide I showed you earlier on. So clearly, one of the most important metabolic actions of testosterone is insulin sensitization. Next slide. And you can see here changes in free fatty acids, which cause insulin resistance, falling with testosterone, changes in plasma leptin, falling with testosterone because adiposity is going down. Next slide. And you can also see all those 4 indices that I talked to you about earlier, which were defective, diminished in the hypogonadal patients. They all rise with the treatment of testosterone. So beta subunit of insulin receptor, RS1, AKT2, and GLUT4, all of them rise to levels comparable to the eugonadal diabetics. Next slide. And here you have AMP kinase also, as I mentioned earlier on, rising to levels comparable to those in the eugonadal patients. Next slide. And additional sort of elements that were shown to be low in the hypogonadal patients were SOX3, which interferes with insulin signaling at RS1, I-kappa kinase, which also interferes with insulin signaling, and PTEN, which also interferes with insulin signaling. And you can on the right see the fall in CRP and fall in TNF alpha, two major characteristics of inflammation. Next slide. And here you have, again, another very interesting phenomenon. So you would have expected, and I did when we did this study, to look at it to androgen receptors and estrogen receptors. I expected androgen receptors to be higher in these hypogonadal patients. But lo and behold, in fact, nature turned out to be doing something different. Androgen receptor expression was lower, estrogen receptor expression was lower, and aromatase expression was lower. So clearly, not only do you have a low testosterone, even the receptor for testosterone is down. So it's a double whammy for the patient. And you can see why these patients who are hypogonadal can be very miserable. And then when you give the testosterone, the whole situation reverses, including the receptor population. Next slide. And then you have here, again, androgen receptors and changes with treatment. Let's move on to the next slide. Yeah. So in the muscle too, the same sort of situation, and both in the muscle mRNA and protein, the expression is diminished, and then when you give testosterone, the androgen receptor increases. So sensitivity to testosterone also increases along with the testosterone concentrations. Next slide. And then on to action on muscle itself. We've known for a long time that testosterone is used for bodybuilding by bodybuilders. And the understanding as to how and why it happens is still not complete. So we have begun to scratch on that area and begin to dissect it out. So let me show you the findings. And what this slide is showing you is the satellite cell, which sits along with the mature muscle cells. And this is the one that gets stimulated and increases in size and becomes from a satellite cell into the muscle cell. And that's the secret. Next slide. And you can see here that IGF-1, IGF-1 increases. So IGF-1, as you know, is an insulin-like molecule, but stimulates very many metabolic functions. But one of the functions is to stimulate the muscle. And so one of the factors causing the increase in the muscle size with testosterone would be IGF-1. The second factor is on the right, FGF2, fibroblast growth factor 2, and you can see that it's also increasing steadily with time over the period of 6 months. Next slide. And again, now you have some other finer points here. FGF2 mRNA, again, showing an increase and so on. And then myostatin, which is the factor which suppresses muscle growth. It's been known for some time, and actually drug companies are working on myostatin suppressors to increase muscle growth. But lo and behold, testosterone does it all by itself. You don't need any other medication. Next slide. And then on to, again, another study. Briefly, I'll just sort of jump over it, basically showing that testosterone therapy over the course of 1 year reduced the A1C and increased insulin sensitivity. Next slide. So that study confirmed our data. Next slide. So then, what is it that testosterone is doing? Reducing fat mass, increasing lean body mass or muscle, increasing insulin sensitivity, improving glycemic control, and of course, in these short-term studies, there is no way to demonstrate whether cardiovascular disease changes, and these trials are currently, prospective trials are currently going on. Next slide. Now, I'm coming to something really hot now. And this is a study that is just this earlier this week. been put onto the internet by Diabetes, Obesity, and Metabolism. And it's a study we did in collaboration with Farid Saad's group in Germany, because they have a very large registry of hypogonadal patients. And as you can see, there were 178 patients in the testosterone group and 178 patients in the control group that did not get testosterone over a period of 11 years. And what is dramatic about this slide is almost like science fiction. See the green line, the steady fall in weight with testosterone over this period of time. Next slide. And here you see changes in A1C. Dramatic change in the T group, while the control group keeps doing whatever the type 2s do. So can you hear me now? Hello?
Yes, sir.
Okay. So now, as a result of the weight loss and of the improved insulin sensitivity, what we've now published in this paper, which is just published earlier this week, is a remission of type 2 diabetes in 34%, one third, normalization of blood glucose with, obviously, with treatment in 46%, an achievement of A1C of less than 6.5 in 83%, and less than 7 in 91%, over a period of a mean period of 8 years, although the study lasted 11 years. This is remarkable. And this allows me to say, without any inhibition, that every type 2 diabetic, every obese person must have his testosterone measured. And if it is convincing to the clinician, he must get on with it and treat the hypogonadal state, because it's not just sexual function, it's metabolic function, including diabetes. And if diabetes can be reversed, why would you not at least want to control it well by giving testosterone at the same time and making the person feel better? Next slide. And here the further indices, I think I'll leave that. Let's jump on this one, leave that, waist circumference walls, and so on. So basically then, testosterone is not merely a sexual or lifestyle hormone, it's a metabolic hormone, as and it increases insulin sensitivity, decreases fat mass, and increases muscle. And in general, energizes the patients to get back to their normal state. Next slide. Jump on this one. Next. And of course, you've seen this already, but I wanted to rub it in. But look at this. In this large series of 178 versus 178 patients, those who got testosterone versus those who didn't, look at survival, death rate. I mean, this is really mind-blowing, the difference between the two arms. So let's look at some further details. Next slide. Go on. Next slide. 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 Yeah. Now look at this table. I hope that you can see it in detail on your. Look at the number of myocardial infarctions, major adverse coronary events, myocardial infarctions, strokes, myocardial infarction and stroke, and then diabetic complications of retinopathy, nephropathy, polyneuropathy, diabetic foot syndrome. And then falls with fractures. And of course, that's partly a function of the hypogonadal state making you lose your muscle. So dramatic changes. But remember that although these are statistically significant within this study, clearly we need prospective studies to confirm this. And it'll take some time. But in the meantime, you have these startling data to go by into your day-to-day practice. Next slide. Okay, now on to the latest. This is not published data, and the data just came up about 4 or 5 days ago, and I've just been working on it. And this is very exciting. So these are obese adolescents, and they were subjected to bariatric surgery. This is the only bariatric surgery study published in adolescents from the United States. So the mean age was 17, range 14 and a half to 19 or to around 20, and the average total testosterone at baseline 194. And what is the baseline for normal values? 300. So clearly 100% of them were hypogonadal and would probably never have reached puberty. And then they had their bariatric surgery. And fortunately, we have samples over 5 years, sequential samples. So let me show you the data. Next slide. So here it is. The weight fell from a mean of over 160 kilos down to around 120 kilos. So they were still not exactly normal in weight. It was still over, but even so, it came down dramatically. Next slide. And you can see a curve in the opposite direction. And this is total testosterone. And you can see that it hits 500, which is middle of the normal range. This kind of data have never been published before, that bariatric surgery in obese children who are almost universally hypogonadal will become normal within 24 months, as you see in this slide, and the levels are maintained in general. However, as you know, bariatric surgery is also associated with regain of body weight. So I deliberately looked for those data as to what happened with regain of body weight, because some of them can't maintain it. Next slide. And here you can see the correlation again, similar to the one we had shown you earlier, between the BMI or change. Here it is change in weight with change in testosterone, linear relationship. Next slide. And here you see the drama. My God. What you see here in the red and the orange curves is the weight. So you have those who regain weight versus those who maintain their weight after weight loss. So the light orange color is those who maintain the weight loss, whereas the red color is in those who regain more than 10% of their weight after weight loss. And what you see amazing parallelism with the testosterone. So those who did not regain weight maintained their testosterone levels. But those who regained weight, you can see the blue line shooting down and converging with the weight line. So clearly, body weight, on the basis of all the data that I've shown you, is a major determinant of testosterone concentrations. And I think this story is just sort of getting fortified, if you like, but there'll be further developments as we go on with this story. And therefore, I'd like to conclude my talk with the fact that whether you're a diabetic, type 2, or you're obese without diabetes, you have a very significant risk of being a hypogonadal person. And hypogonadism is not just going to manifest itself in hypogonadal sexual state. It's much more than that. The hypogonadal state is an insulin resistant state. It is an obese state. And these elements then add to not only diabetogenicity, but to cardiovascular risk and disease, as you saw. So one of the lessons from here is, of course, never become obese, but certainly, even if you can't help yourself right now as an adult, make sure that your children and your grandchildren never become obese, because that will be a curse in addition to the other curses that obesity brings along. So thank you very much for your time and attention. But as you can see, this is a very exciting developing area at this moment.
Thank you, sir, for a wonderful oration on